Okay, I think we'll go ahead and get started. Kathleen, if you wanted to pull up, I think we're going to, before we jump into the loss of appetite session, we're actually going to proceed with our land acknowledgement. We would like to acknowledge that the land which we are gathered on today is the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of Chippewas of Beausoleil, Rama, and Georgina First Nations, and more recently, the Mississaugas of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements, and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish, One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for this land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. Thank you so much for joining us today. We're excited to have you here for our second session of our series. Today we'll be covering the loss of appetite. The Palliative Care ECHO project is a 5-year national initiative, which most of you are already aware of, and it is to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. For more information, you can go to the ECHO Palliative Care site, echopalliative.com, or visit our site as well, nsmhpcn.ca/echo. We would like to thank Health Canada for their support of the project. It wouldn't be possible to do what we're doing today without their financial contribution. And now I would like to introduce myself. I'm Amanda Tavelda, Communications, Fundraising, and Public Relations Specialist with Hospice Aurelia, and I will be your host and moderator for today. So I will be keeping an eye on the chat and helping out our presenters with any questions that might come up while they're discussing. Today's presenters are Julie Layton-Phelps and Kathleen Bartlett, both with the North Simcoe Muskoka Hospice Palliative Care Network. Ladies, the floor is all yours.
Thanks, Amanda. So hi, everyone. I'm Kathleen. I'm a registered nurse and hospice palliative nurse consultant with Network, and I look forward to hearing our conversation today.
Hi, my name's Julie Layton-Phelps. I'm a nurse with the Hospice Palliative Care Network as well, and looking forward to this presentation and your feedback.
And if you guys don't mind utilizing the chat box and just giving us an update as to your profession and whereabouts you're coming from, that would be great. So Cancer Care Ontario has developed several cancer-related symptom management algorithms. These algorithms can be used for any life-limiting diagnosis, not just for cancer. These algorithms are not intended to be used of standards of care, but rather for clinical tools to be used for appropriate patient care. This presentation focuses on the adult population. The pediatric population has their own unique challenges and interventions for symptom management, and we will not be touching on that today. So some of the learning objectives for today are by the end of the session, you should be able to understand loss of appetite as a palliative and end-of-life symptom, recognize the features of the symptom of loss of appetite, and to gain the knowledge needed through case-based learning to assess and manage symptoms. So loss of appetite is the inability to consume optimal nutrition with resulting weight loss and nutritional deficiencies. Poor nutritional status can affect tolerance and recovery from cancer-related treatments, decrease function ability, and lower your quality of life. It's a universal symptom of multifactorial syndrome or cancer cachexia. So what is loss of appetite? These are just some of the common definitions. So Loss of appetite is one of the most common problems that can occur in end of life, and with those dealing with a cancer diagnosis, it leads to reduced intake and therefore nutritional deficits and significant weight loss if left untreated. Anorexia is defined as a loss of appetite or wanting to eat. It may be associated with early satiation, medication side effects such as constipation, fecal impaction, nausea, vomiting, gastro issues or malabsorption, dysphagia, depression, anxiety, or any other oral problems, metabolic disorders, altered taste or smell, odors of the food itself, or generalized weakness and being lethargic. Cancer cachexia, this is defined as a condition often leading to functional impairment and is characterized by the loss of muscle mass that cannot be restored. Secondary cachexia is the quick intervention, can impact the quality of life and is characterized by causes which may be able to be corrected. And then there's also primary cachexia. So pre-cachexia is based on having the following: chronic disease, unintentional weight loss of less than 5% of your usual weight over a 6-month period, chronic or recurring inflammatory response, anorexia and related symptoms. Cachexia is weight loss that is typically 5% or greater over the last 6 months. They have a reduced food intake, loss of muscle mass, or related to a systemic inflammatory response. Refractory is usually untreated, and with cancer is pre-catabolic and is not responsive to treatment. And then there is sarcopenia, which is shown with loss of muscle mass, muscle strength, and is usually seen in aging. There is sarcopenia obesity as well. It is defined as an increased body mass index, but associated with depleted lean body mass tissue and function. An obese patient with an underlying disease with an unintentional weight loss of less than 5% may be considered pre-cachectic, and an increase in fat mass may hide the loss of lean body mass. So we're going to be looking for that. So when does the loss of appetite impact someone? It can be at end of life, during their cancer and treatment, during medication use, traumatic injuries leading to impairments, aging, emotional or physical stresses, disease progression. So this can include HPV, syphilis, herpes, gonorrhea, emotional or physical stresses, life-altering events such as CDA, motor vehicle accidents, brain injuries, or spinal injuries. At the end of life, eating and drinking can be caused because they may not be able to feel the need to take up as much food for their energy. Their energy stores will be depleted. People may not also want to eat. There's the risk of aspiration. So always ensuring that care providers are talking to their healthcare providers, trying to try to give someone who is end of life anything to eat. And if they aren't able to eat, to ensure that adequate mouth care is available, or offering them sips of water, fluid, or even hard candies, just to ensure that those mucous membranes are staying moist to reduce the risk of infection, splitting, and sores. So some of the stages of appetite loss: there's mild loss of appetite, which is considered anorexia or pre-cachexia, which is a weight loss again of less than 5% in the last 6 months. Treatment and medication related to anorexia or weight loss, and it's not subjective to dehydration. Moderate loss of appetite, again, anorexia or cachexia, is weight loss of greater than 5% in the last 6 months. It can be tumor treatment or medication related, and it could be also caused from the C-reactive protein lab value for inflammation. Some of the other stages are severe loss of appetite, which is refractory cachexia. It can lead to extreme sarcopenia. It can be from advanced disease, progressive loss of muscle mass with functional impairment, and this is usually with a low PPS. So this is just kind of the trajectory that you can kind of see, the different stages. So pre-cachexic cachexia, and then refractory cachexia, which inevitably will lead to death. And this is just a diagram showing how the muscle wasting can occur from all of the different organs. And cancer cachexia. One of the quotes from a case study from the Women's Fitness, online states, in patients with diseases such as cancer or AIDS, loss of appetite can turn into a wasting disease called cachexia, also known as the last illness, because it can accelerate a patient's decline. So this here is just a little video, again, giving the definition of cachexia.
Cachexia is a condition characterized by malnutrition, extreme weight loss, and muscle wasting. We created this video to cover the medical definition and provide a brief overview of this topic. So, if you're ready, let's get into it. As previously mentioned, cachexia is considered to be a wasting disorder because it causes extreme weight loss and muscle wasting. It often affects patients who are in the later stages of a serious disease or condition. Cachexia is most often associated with end-stage cancer, but some other examples include AIDS, kidney disease, CHF, and COPD, among many other chronic conditions. Experts believe that cachexia occurs due to the body's response to fighting a serious disease, although a precise physiological cause is still not known. With that said, it does result in weight loss, which is a goal for millions of people around the world. However, the type that occurs with cachexia is different because it happens involuntarily. And unfortunately, it causes mostly muscle loss instead of fat loss. This is due to metabolic changes that occur within the body that causes the breakdown of muscle tissue. Treatment for cachexia depends on the general prognosis and current signs and symptoms of each individual patient. Therefore, the most common effective treatment method is to provide care for the underlying condition that resulted in cachexia in the first place. With that said, the following may be helpful in slowing down the rate of muscle loss as much as possible: exercise, a nutrition regimen, taking supplements, and certain medications such as appetite stimulants. Unfortunately, cachexia has a poor prognosis and is associated with increased mortality and a poor quality of life. Again, for this video, we just wanted to provide you with a brief overview of this topic. We'll be breaking it down into much more detail in a separate video. Real quick guys, do me a huge favor and hit the like button. It really helps support the channel because we have a ton of other videos on our channel that I think you will enjoy. Just a quick reminder, we are not...
Go ahead, Julie.
Thanks, Kathleen. So we're going to talk about a team approach to care. So you can see by that list, it's just some of the examples of team members that would be on someone's caseload if they're suffering from loss of appetite. First and foremost is the patient and their family or caregiver. And then all the way from doctors, nurses, dietitians, social workers, spiritual or religious supports. A team approach in palliative care is essential for the provision of appropriate and optimal care to a person with a life-limiting illness and their family. These team members may be involved at different points during their journey, and thorough communication is required for seamless care. So how do we diagnose loss of appetite and cachexia? So to diagnose most illnesses, doctors will use a differential diagnosis. So some of the possible causes are very plentiful, but I will mention a few. So infections, gastrointestinal illnesses, so that includes viruses, bacterial and parasite infections, change in your taste buds, post-op recovery. So if they've had cancer-related surgery, they will probably go through a period of lower appetite. Eating disorders, so the anorexia nervosa, acid reflux, food poisoning, allergies, food intolerances, stress, alcohol, drug use, medication side effects, diabetes, grief, anxiety, and depression. So lots of things to rule out before we come to an actual cause. We also do height, weight, and BMI measurements, laboratory investigations, and screening and assessment tools. The next couple of slides just kind of give some possible causes. So tumor related, like the dyspnea, fatigue, they're too tired to get up and make themselves something to eat. Chemo can cause nausea, vomiting, bloating, all those kind of things. There's some surgical and systemic and radiation treatment related ones. Dry mouth is really common with many of the treatments for cancer, as well as some of the other medications and some of the other chronic diseases. Use of opiates, use of antidepressants can cause dry mouth and nausea as well. And then there is always usually a psychosocial component. So anxiety, depression, delirium. The fear of eating is significant because they don't want to make any symptoms that they're currently having worse or have new ones come on. Lack of financial resources is huge, especially in our senior population. If you ever were to do a home visit and look in their fridge, you will probably not see a balanced diet worth of food in there. Yeah, so lots of different possibility of causes, or even multiple causes that could be affecting one person at a time.
So some of the assessment tools that you can use for this are the acronym of OPQRSTUVW, which I'll go over in a second, the ESAS, there's a malnutrition screening tool, which is more geared towards the dietitians, the global assessment tool, which is more oncology based. There's physical assessment tools, medication assessment tools, and then looking at lab reports, of course. For lab reports, some biomarkers for cachexia include a high CRP and low albumin levels. The CRP measures an inflammation process, and then anemia and decreased LUCs may also be present. Early recognition and detection of poor nutritional status is also timely and allows for appropriate interventions then, and always ensuring that you're being proactive with your patients. So this is the ESAS. This should be completed by the patient themselves at each visit. If they're not feeling up to it, you can always leave it at their bedside and ask them to fill it out whenever they get a chance, so that the next time you come in, you can see how they were that day. Some other symptoms, including anxiety, depression, shortness of breath, pain, may also influence someone's appetite. If a patient's in a lot of pain or is too short of breath, they may not feel like eating without increasing or exacerbating those symptoms. So this is the acronym. So O is onset. You can kind of read here what it is. When did you notice your lack of appetite? Is it there all the time? P is provoking or palliating. Is there a time of day when your appetite is better or worse? What do you think the cause may be for your lack of appetite? Has a patient had any recent surgery or treatments that may be impacting their ability to eat? Are they taking any medication that's impacting it? Like Julie said, a lot of dry mouth issues. There's Q is quality and quantity, comparing to their normal food intake. Do they describe their eating habits as the same as they were previous? Are they drinking enough fluids? Are there other symptoms that are impacting their ability to eat? Any nausea, vomiting, constipation or diarrhea, sore mouth, dry mouth, changes in tastes? Are they having food aversions due to odors? Any problems with swallowing? Feelings of fullness, pain, shortness of breath, depression? The severity is how much is your lack of appetite affecting your activities of daily living? Are they able to still do things that they normally do, or do they just not have the energy because they're not actually intaking food and their disease is progressing? Treatment, are you doing anything to help manage your loss of appetite? Like in the previous slide, exercise, medication, changing their diet, offering smaller meals, and is it working? U is understanding and the impact it has on them. Is it impacting them or their family? Are they feeling distressed about their inability to eat? And have they experienced or had any pressure from family related to their eating abilities? We'll sometimes see that in end of life, where families show their love through food and they feel that if their loved one isn't eating, they're not necessarily wanting that, which isn't the case. It can do more harm than good, trying to force food upon people that are not wanting to at end of life. The values, are there any other views or feelings about the symptom that are important to you and your family? So exploring the need for food again, like I've mentioned, it could be just a sign of love and they're just misunderstanding the patient. And for weight, have you lost weight recently without trying? If yes, how much? And over what time frame? So that's always a question that we'll ask in the ESAS. And have you been eating poorly because of a decreased appetite? So these just validate your ESAS scores that you would have completed and support the diagnosis and the types of loss of appetite. So we can also do a nutritional intake history. So it's just diet history for macro and micronutrients, the fluid intake, what they're drinking, how much, etc., how often, are they consuming any alcohol, are they taking any nutritional supplements like protein drink, Boost, Ensure, Resource, are they on any pre-existing diets or specialized diets if they have any kidney or cardiac issues, are there any food avoidances, aversions, allergies, intolerances, or sensitivities, etc. So just making sure you're going through those questions. There's also the nutritional screening tool. So this is what it looks like here. So it's short and easy to complete, and it validates cancer patients receiving chemo and radiation. It primarily asks about appetite and unintentional weight loss. Scores greater than 2 indicate that there is a significant nutritional risk here. So you can just go through and they had kind of made up some scoring. And then the action that you would do. So refer to a dietitian for full assessment and intervention, ensure that you're documenting properly, record the weight of the patients on admission, and then however often the physician is wanting you to do that, weekly, monthly, and then rescreening your patients just so that you're able to monitor that weight loss sooner rather than later so that you can intervene if able. There's also the patient-generated subjective global assessment tool. So that's what this one looks like. It's a validated tool and it's more comprehensive than the previous one that I had just showed you, the MST. It assesses weight loss, change in food intake, symptoms affecting your intake, functional status, disease and metabolic stressors, and then it also includes a physical assessment. Many cancer centers may use something similar to this, but it just doesn't include the physical assessment section. So this is just some more of the information there. So you can see the physical assessment kind of in the center. I'm not sure if you can see my notes or not. And then weight loss in general. The percentage of loss in relation to the time is a hallmark criteria used to evaluate the likelihood for malnutrition. So greater or equal to 5% of loss of weight in 1 month, greater to or equal 7.5% in 3 months, and then greater to or equal to 10% of weight loss in 6 months. Some of the detailed physical assessments that we can complete are height, weight, and vital signs. The severity of wasting, just depending on if you look at a person's face or just their overall body, temporal, clavicular, or quads, you'll notice that muscle wasting. Skin turgor, they're dehydrated, the mid-arm circumference, skin fold thickness, their overall appearance and posture. Cachexia, they'll kind of hunker over. Hepatic or uremic, I think that's supposed to be factor, not feeder. Skin color, so paleness or jaundice. Edema, the location, look for pitting and non-pitting and the degree of it. Just making sure that you're recording that. And then checking for their gross muscle strength, their gait, and completing the walking test. Checking for any dry mouth or sores in their mouth, poor dentation, bleeding, ill-fitting dentures, neck and liver or spleen masses, so feeling the abdomen, and any signs of congestive heart failure, postural hypotension, and their hydration status again in relation to the skin turgor, and checking for ascites, bowel distension, auscultating for bowel sounds, and fecal impaction. So some of the lab investigations that I had mentioned previously are the CRP. You can also do a CBC with differential, including the total lymphocyte count, a blood glucose, electrolytes, calcium, magnesium, and phosphate, checking for their liver, renal, and thyroid function levels, and their albumin levels. So C-reactive protein is nonspecific, but a sensitive marker for the inflammatory process associated with a decreased appetite. It can tell us about the performance status and survival. It is positively correlated with the one scoring tool that I had showed you that had the physical assessment linked to it. And the consideration of the CRP in conjunction with other factors, including weight loss and low food intake, may help to determine the difference between anorexia and precachectic patients.
Okay, now we're going to focus on management, so pharmacological and non-pharmacological interventions. So how do we manage loss of appetite in those who are palliative or end of life? So for managing this symptom, it's important to do all the proper assessments and their ESAS scores, so we can trend them to see if we're starting to notice that they're suffering from any of the ESAS scores that we're looking at. Just like I would have somebody do a pain journal, I would do a food journal. What are they eating? When are they eating? How much are they eating? Is there any symptoms they're having before or after? And are they taking any medications currently to control their symptoms? Are they taking any nutritional supplements? So any of the drinks, bars, shakes, as well as vitamin replacement. It's important to involve an interdisciplinary model of care because there could be so many reasons why physical, psychosocial, spiritual reasons, all those other domains that we assess in each part of their palliative care, loss of appetite is important as well. And consulting with the palliative care team early before things become a crisis. To manage loss of appetite effectively, this cause of the symptom needs to be determined. So the treatment options may have some differences. So like cancer-related loss of appetite versus anorexia nervosa. Some of the risk factors are modifiable, like medication side effects. So we could try changing the medications to see if there's less nausea involved with that. But some of them we can't change. So the actual disease process, their age, body functions. Management strategies are also very individualized based on the assessments, and of course will change throughout their journey of their disease. So when you're going from active treatment to quality of life and end of life care, it's going to change. Some of the non-pharmacological interventions. So we would use the PPS scale and the ESAS to kind of determine where they're at in their journey. But also probably the most important thing is talking about their goals of care. What are they willing to try? What do they want? What are their wishes, their values? Like I said, food culturally is very important to some people and others not so much. And then help teaching other ways of providing that care and comfort. So mouth care, massage, reading, distraction, right? Managing the symptoms that may be impacting their appetite. So, obviously if they're having stomach pain, which is causing them to not eat because they know the eating will cause their pain. So we need to control their pain. If they're constipated, we need to treat that. Intervening early is important with all the other therapies, so supplements, exercise, and we need to address any fears they may be experiencing. And then depending on what interventions may be suggested, and of course, always refer back to their goals of care. Some of the other non-pharmacological interventions include psychosocial, cultural issues, accessibility to food and financial difficulties, nutritional education strategies, exercise, which is very important, referral to the dietitian early on before it becomes a crisis. And if there's any swallowing issues, then referral to a speech language pathologist. Ensuring that they are able to swallow and are not risk for aspiration. We encourage them to try frequent small meals instead of having 3 big meals. And snacking is important, not grazing, but snacking, just to keep their protein and their calorie intakes up. Avoid food with strong odors. Many illnesses and their treatments, including chemo, can affect their sense of smell and taste. So some of these foods, which I don't like any of them, Smelly cheese, seafood, Brussels sprouts, oiled eggs, fried foods. Instead, depending on what type of diet, if they need to be cardiac, diabetic, you can add spices like, I'm just trying to think, think of some. Mrs. Dash is one of the ones that have quite a variety of spices that are not too overpowering and just add the right amount of flavor. Sometimes you can add some natural appetite stimulants, so ginger, fennel, cloves, garlic, cardamom, and green tea. Ensuring constipation and nausea are well managed, so often we will encourage them to take any medications they've been prescribed before they eat. Ensuring they're hydrated, limiting the caffeine as it's a diuretic, and utilizing those higher fiber foods to keep the water within them themselves, so fruits, veggies, and grains. If there is a significant issue with nausea, you can do the bland diet like the brats, so bananas, rice, applesauce, and toast. Ginger cheese are really good to help with the nausea. And then sometimes sucking on popsicles, hard candies, or ice chips will help with the mouth dryness that's associated with a lot of medications and treatments. If they can't take actual solid food, then we encourage supplementation with the protein drinks, the Ensure drinks. There's quite a variety. Ensure has one that's been out for quite a while. It's about half of the serving of a regular Ensure drink. It's more concentrated. So you're getting the same nutritional value with the minerals and the vitamins for half of what fluid there is. So it's more concentrated to get all the important stuff in without overloading your stomach with all that fluid. Try not to use the supplements as their sole nutrition. But if that is the case, I know in Ontario, the doctor can write a prescription and it can be covered. So it does get expensive after a while. So if that is their sole source of nutrition, then they can get some financial coverage for that. Be supportive of the patient. Try not to be like too pushy with food. You can encourage, but not pushy. We don't want to make them feel like they have to eat to make everybody else happy, which in turn would possibly make them sick. They often have issues of depression, feelings of isolation and loneliness. So try and make meal times a social event, have family friends over, watch a movie. You know, setting some realistic goals will help them as well. Some issues to make meal times more enjoyable. So sitting with your family, watching a movie or a show, nice table settings, nice plates, some flowers, just, you know, make it more enjoyable. Have some music and some mood lighting, eating their favorite foods, and making time for the meals. So like I said, try to do 6 mini meals a day instead of 3 big ones. And also good dental care is important for taste and swallowing. Some of the medication treatments that we could use group-wise are corticosteroids, prokinetics, and synthetic progesterones. So the next slide is the graph from the guidelines from the CCO regarding loss of appetite. So often with the corticosteroids, we use dexamethasone or prednisone. Be cautious with diabetics because the steroids themselves will increase their blood sugar quite high, and can cause other issues like yeast infections and thrush and that kind of stuff. Often they are prescribed PPI or protein pump inhibitor. Just it is a bit hard on the stomach. You can see from the side effects, it can cause edema, gastric irritation, thus the PPI, high blood sugars, insomnia. So try to take it in the morning, not in the afternoon or at night. Otherwise, they will be awake for a long period of time. The next one down is prokinetics, more for chronic nausea, associated more with the cachexia part of it, and some issues that may result in gastroparesis. So using metoclopramide or Maxarin, just be cautious if there's a suspected bowel obstruction, we can't use that medication. Domperidone before meals. And then, yeah, based on their kidney function, their age, there may be some precautions that a lower dose may need. So sometimes the prokinetics can cause diarrhea, which would cause dehydration, would cause weakness, drowsiness, restlessness. Synthetic progesterone, so this is your Megace. This is one that's used more in oncology versus other issues. It could cause edema or DVTs, high blood pressure. Yeah. Some other options that aren't listed there are THC, so Marinol and Avalone, which are the man-made government-regulated cannabis. The biggest issue with that is it could possibly be habit forming. So if none of the other meds listed above are not effective, then this is something we could try. It stimulates appetite, especially in those with HIV, if you take an hour before lunch and dinner. And it also prevents nausea and vomiting from the chemo. So their first dose of the day would be on an empty stomach 30 minutes before eating. And then the second and third dose can be taken with or without food. Some of the side effects from the THC is new or worse psychosis, increased or lowered blood pressure, vision changes, increased heart rate, changes in behavior, or dizziness. So just some of those side effects alone may not be appropriate for this medication to be used in some people, especially the elderly. For nutritional supplements, they come in all kinds of things now: shakes, snacks, bars, candy. You can use them as snacks. You can use them as a full replacement. Like I said, try not to make all of the meals with the nutritional supplements. Glucerna is good for the diabetics. You want high protein, high calorie. Some of the vitamins that may increase appetite include zinc, thiamine or B1, and fish oil, so your omega-3s. Some of the ones that we have in Ontario include Boost, Ensure, Resource, Greens, and generalized protein drinks and powders. I would not use any of the weightlifting ones. It has a lot of other chemicals in there that would not be appropriate for someone with this condition. End of life nutrition, so primary cachexia, the refractory stage. So hyperdermocolysis, we rarely use this, even at end of life, for hydration. Assessing the PPS, the ESAS scales, and of course their goals of care. Patient and family education is top of my intervention list. I have been accused of starving someone because they cannot swallow safely. So this is where education comes into play, and then they get it. Or when they see them choking, and having difficulty breathing, or the aspiration pneumonia that they get, often will change their mind about pushing the food and fluids on them. If they can still swallow, ice chips, small sips of fluids are okay. You can thicken the fluids to nectar, honey thick, based on their swallowing ability. Being sensitive to cultural and rituals around the importance of foods and fluids is really important. Some families I've dealt with, just as long as the spoon with that particular food touches their tongue, they're okay. They don't have to eat it and swallow it. It's for comfort, right? And like I said, I've had lots of issues with families and patients regarding when we have to stop the eating and drinking due to safety reasons. It is such a source of emotional distress. explaining the pros and cons. So, you know, yes, they would get to taste the food, but the risk of aspiration pneumonia is too high. Looking for those alternative things that the family can do. So massage, mouth care, reading to them, distracting. Usually our patients at the end of life are not hungry, they're not thirsty. And so to be pushed these items on them can be so distressing to them as well. And they often do it to appease the family. And then of course, family feels helpless that without feeding them or cooking for them, they feel there's nothing else they can do. So this is where we teach them how to do all the other things. Yeah, so developing an individualized care plan throughout their trajectory and their journey. So knowing what their prognosis is, also knowing what some of the other comorbidities are. People don't just have cancer anymore or have dementia. They're often arthritic. They often have blood sugar issues, all kinds of heart issues, blood pressure. So we have to look at not just the illness that they're dying from, but all the other comorbidities as well. Listing the assessment tools. So for continued use, each person is using the same tools so we can trend those results. List the medications so we can be aware of any potential interactions, side effects, adverse effects. What is their functional status at the time of assessment? And then that needs to be updated as there are changes. And like I said, goals of care are very important because what we think the person may need is not what they want. So I always change them. I always refer back to them anytime we suggest an intervention. Is this okay with them? So next we're going to do a case study. So Kathleen's going to read the slides a bit and I'm going to ask some questions. So feel free to use the chat or unmute and yell out your answers. And just remember, no answer is wrong.
So our case study for today is a 78-year-old recently diagnosed with gastric CA. He's been referred to the cancer center and is scheduled to start chemotherapy and radiation shortly. He presents with pain in his left upper quadrant of his abdomen and initially says that it's getting worse, but is now associated with nausea. He is hoping for something to control it, and Mr. Green asks you to call him Trent.
So just from what Kathleen has read, what are some of the risk factors for loss of appetite, malnutrition, or cachexia in this man, just from what you see on this slide? Laura says chemo radiation, correct? Nausea, pain, the actual cancer, the nausea, correct? What about his age? Does his age affect his appetite at all? Lisa says yes. 2 yeses, correct, correct. So, I mean, not everybody is one of those tea and toast elderly people, but of all the seniors that I know, their appetite is definitely less. They're definitely intaking a lot less than what they had done in their middle adulthood. Okay. I think also stress and anxiety related to his diagnosis can certainly play a factor.
So for Trent's social history, he's married and lived with his wife, Sophie. He has been her main caregiver. He's an electrician by trade and a building contractor, and he owns his own small company. He smoked heavily until about 10 years ago when he quit, and he describes himself as a social drinker, admits to, and every now and again he has one too many. He has 2 adult children and 2 grandchildren. His son and daughter live in the same town as him.
So from the information provided in this slide, what other risk factors can you identify for loss of appetite and malnutrition? Caregiver stress, correct. Take caring of wife, loss of income, yep. ETOH, yes. What about the smoking? Even though he quit 10 years ago, do you think the previous smoking history could affect? Yes. Does he have any comorbidities? So yeah, there's certainly lots of questions we can certainly add. So yes, doing a comprehensive assessment would be great with him. So yeah, so stress as a caregiver is good. Even as is business, like running a business is stressful, let alone now he has the financial stress of not being able to work during treatments. And definitely, yeah, his current and past use of alcohol.
So his medical history includes hypertension. He is well controlled though and on medications. He has mild osteoarthritis, and he did have depression several years ago. This resolved after several months of treatment, and he has not been on any antidepressant medication since.
So does anything in this health history alert you to other risk factors not already identified? Pain, yes. Yeah, lower mobility due to the arthritis. Prone to depression, correct? Right, lots of depression ones. So yes, you know, like for my experience with depression personally and with my patients, even though it's resolved, you're definitely always at risk for it for returning. And if he was actually still on his antidepressants, that would be a risk factor for lower appetite. But in this case, that he hasn't been on, but it's just something to be aware of what medications will decrease your appetite. So a lot of what he has are some fairly common comorbidities, right? And we need to make sure they're well controlled as we are treating his cancer.
Some of his current medications that he's taking are hydrochlorothiazide for his hypertension, extra strength Tylenol for his osteoarthritis, and he's been taking 2 to 3 tablets a week, but he's now taking 2 to 3 tablets a day. His allergies, he says he doesn't think so, but he did experience some nausea when given morphine for an injury a few years back.
So we know Tylenol is hard on the liver. Some people may find it's irritating to the stomach, not as much as if he was on an NSAID. So he's not, you know, he's definitely no polypharmacy unless he's not admitting to taking other medications. Didn't ask about vitamins or anything like that, but yeah, you know, he needs to inform his care staff if he adds anything, right? So we can make sure there's no adverse reactions with mixing the medications. So, oh, sorry, Kathleen.
And how would you treat Trent, or sorry, how would you assess Trent and his nausea? What tools would you use?
ESAS, correct? Yep, the LPQRS TUVW, the malnutrition screens, correct. Physical assessment, yes. Also weight loss measurements.
So his nausea history, it started about 4 weeks ago, but continues to get worse. It's mainly consistent. It does improve a little with food, but then it gets worse again. His location, he does have gas pain. He is passing gas and he is belching often. Severity, he rates it 6 to 7 out of 10, and it worsens again with large meals. So just completing that ESAS tool that we had mentioned on how we would assess him for his nausea. And when we did that, we found what worsened Trent's nausea included large meals, spicy or greasy foods, and when he takes his meds on an empty stomach. What improves his pain is when he eats smaller meals, bland foods, or soups. And then some of the medications that he has tried previous to manage his nausea and that was effective, or how effective it was, included ondansetron. It helped when he was on his chemo, but it did make him constipated. And Gravol did help him, but it made him too sleepy. So his impact on functioning, he was unable to go for his walks in the evening. It was something that he used to enjoy. It did impact his mood. He felt quite frustrated and sad, and then he was concerned that he would be suffering a lot, so he avoids eating for the fear of vomiting. And for him, the meaning was, my disease is progressing rapidly. Am I dying? What is it? What is it gets to a point if I cannot eat? Sorry, typo there, guys. So what would you look for in your physical examination then of Trent, given the information that I just shared? We can do like a GI assessment.
Pain, tenderness, bowel sounds, hernias, correct? Yeah. Hydration level, yeah. Skin turgor, looking at the tongue, having him watch his urine to see what color it is. What about a rectal exam? Is that something you would do on this man? Blood work, yes. Mouth and teeth assessment. Does he have poor dentation? Does he have dentures that aren't fitting properly? Does he have thrush, mouth sores, that kind of stuff as well? Yeah, correct, Sherry. So regarding his goals of care, so some diagnostics, ultrasound, scopes. Yeah, for sure. Which kind of goes into our next slide. So I'll take your answer to that, Sherry.
There you go. Sherry's already on it.
Yeah.
So would you order any other investigations?
So we've got scope, we've got ultrasound. What else would you may possibly order if he agrees? CT, correct? Especially if one hasn't been done recently when all these symptoms started, or if the symptoms got worse. Light CBC liver panel, correct? I would also probably do a stool sample, just to check to make sure there's no parasites, bacteria, viral, especially if he's had any travel. Oh. Yeah, the labs, what is his protein levels? What's his albumin? What's his inflammation level? So your C-reactive proteins, LFTs, possibly a flat plate if there's a question of whether or not he's constipated or not. Ultrasound for sure, you know, are we dealing with a possible blockage?
And what type of nausea does Trent have? What is it related to?
Reflux, yeah, definitely could be a possibility. So we don't know when or if he was finished his chemo at this point. So the nausea could certainly be related to the chemo. Yeah, definitely some gastric emptying issues depending on where that tumor is and how big it is. And then, yeah, obviously the nausea related to the cancer itself. And, you know, we have limited information in this case study. So once we had done a thorough assessment, I'm sure a lot more of other issues or causes possibly could have come up.
So how would you manage the care for Trent at this time? What may you include in his care plan?
So list some pharmacological and non-pharmacological interventions. Dietitian, correct. Pain meds, different antiemetics. Maxarin, correct. Yep, 6 small meals, education. Not having that pressure to eat. Ginger tea, good. Food at room temperature, yes. Anything too hot, too cold can certainly be a turnoff, especially if there's mouth sores involved, right? So. Would you try him on some dexamethasone? Magic mouthwash, yes. Good old magic mouthwash. So you could possibly try a course of Dex, but yeah, definitely, you know, at a PPI, low doses, go up if needed. Yeah, and if not on chemo. So there's certain vitamins as well that could be an appetite stimulant. So zinc, omega-3s, your B1 or your thiamine. Pre-medicating with anti-nausea meds is helpful. Mirtazapine, yep. Some people use essential oils. So all the other alternative therapies
Reflexology.
can be helpful. Flavor enhancers. So, you know, there's water enhancers if you don't like plain water. There's Mrs. Dash to lightly add some flavor to your food. Your meal supplements as needed. Yeah. Anyone think of anything else? Okay, well, I think a lot of that's covered. Oh yeah, offer supports to decrease stress, alternative therapies. Exercising as tolerated, correct. Don't lay down right after eating, yes. Yes, for sure. So you can find the algorithm, which is nicely colored on the Cancer Care Ontario's website. And alongside of it is some patient education and the full description of the guideline, which is where we got a lot of the graphs, diagrams, and medication piece from. Some of the other resources we added to was the Canadian Hospice Palliative Nurses Association and a couple of articles as well.
So thank you guys so much for joining us. Remember to complete your evaluation. And if you guys have any questions, you can go ahead.
I don't see any questions as of yet in the chat. Thank you both so much for spending the time with us today. That was a great presentation. And we'll be sure to send out a copy of the algorithm as well when we send out a copy of the recording to everyone who was in attendance today.
Great.
Have a great day, everyone.
Thanks so much, guys.
Thanks.